right. Well, are we okay to start on time? I think so. Yeah? Okay. All right. So if I could start the session here. There may be people filtering in. I'm not sure. I know it was congested at lunch, but this is the personalized medicine session, so if you don't think you belong here, now would be the time to leave. My name is Clarke. I'm a faculty member in the health sector management program here, and I recognize some faces, hello Eileen, as well as a few students. And what we're going to do is obviously have a fairly open discussion. If you could, I'll periodically turn to you and ask if you have questions. If we have questions throughout, we may never get through some of the issues. So if you can wait, I will. I promise. Open this up to questions more than once. And what I'm going to ask our speakers to do is to introduce themselves, because, as I said to them, they know themselves better than I do. And as moderator, I promise not to be the equivalent of the Republican debate moderators who apparently try to lob some nasty questions. So I'm not that's not my intent. Highly friendly, but presumably very informative. So, as opposed to normally starting with women first, we're going to start with Barrett.
Hi, my name is Barrett Rollins. I'm Chief Scientific Officer at Dana-Farber Cancer Institute, and I'm the Lindy Family Professor of Medicine at Harvard.
Hi everyone, my name is Rachel Shaw. I'm the Senior Director of Business Development and Strategy of Integrated Care at Sanofi-Genzyme.
I'm Deborah Morosini, and I'm the VP of Clinical Affairs and Patient Engagement at Foundation Medicine in Cambridge.
I'm Birgit, Associate Director of the Laboratory for Molecular Medicine. It's a mouthful. I'm also, that's a genetic testing company, and I'm an Associate Professor at Mass General Hospital in the Department of Pathology.
I'm the second Birgit. Go on, Birgit Schoeberl from Merrimack Pharmaceuticals, representing discovery at Merrimack.
Thank you. So, when I mention personalized medicine to people, those who are familiar enough with it, they give me a theme. So there's a theme to it, but I hear variations on the theme of what it is. So, I take it in the broadest sense to be both diagnoses and cures targeted to our personal genetics. But I would love for you all to expand on a definition of personalized medicine. Anyone here?
Sure. Go ahead.
No, I was going to say, I probably take the most broad view. I know a lot of definitions base personalization on the genetic information of the patient, but my view is there's all sorts of patient information and many different ways to customize the treatment and management of disease. And so I think all data, including the omics, but also behavior data, clinical data, used to customize the treatment as well as the diagnosis, and ideally prevention, but it's the full data set in my mind.
Okay.
Totally agree with that. I think there's a useful sort of functional way to think about this. That I think most physicians would say that for the entire history of medicine, physicians have been practicing personalized medicine. Everybody's therapeutic management of the person in front of them is to some extent conditioned by the person in front of them using all the data that you're talking about, even before you can do any omics data. And so from a functional point of view, the way I like to think about this is that we're now talking about ways to be more precise about the characterization of the patient in front of us. And so rather than thinking that precision medicine is just the latest variation on a buzzword, that it is sort of adding a layer of precision on top of what has always been personalized medicine.
Just before you go, forgive me, but I thought I am cutting off Barrett from your view. I'm moving over here.
Well, that's not necessarily a bad thing.
No. I'm just going to play myself here, so go for it.
So in listening to this, I was thinking of exactly that when any of us go to our doctor, and you're dealing with some kind of diagnosis, you always have been told you're an N of 1, right? And yet what's been applied heretofore are population-based algorithms. And I think this puts us in a challenging juncture now where we take precision medicine, where we're trying to look at what are the individual algorithms per patient, and yet we're in a payer landscape and in a regulatory landscape that really still goes based on population-based science. And that's all we've really ever known while we've, again, practiced medicine in our best way to be an N of 1 for patients. So I think it puts us in a challenging place where we need to invent some bridging mechanisms towards, until we accumulate the data.
So what can you add to?
Beautiful. You don't have to.
No, but I think I have one thing I'd like to expand into, which is many brand this term personalized medicine with pharmacogenomics, drugs, and the like. Now, given what I do, which is diagnosing genetic disease molecularly, I'd like to actually see personalized medicine branch into preemptive genetic medicine for anything that you should know before you get it. Not just whether you react badly to a drug or something like that, but will you suffer from heart disease when you're older? What do you carry in your genome that you should know that would enable you to alter your lifestyle? So that's my personal quest.
So that's more consumer genetics, right? I mean,
Absolutely not. No,
Okay.
I think in my mind, medicine today is very reactive and should be proactive. We treat people when they're sick. We should be informing them before they get sick and help them avoid illness. So, and that should be done in a healthcare setting because it is being done in a direct-to-consumer.
Yeah, I kind of love
which
the direct-to-consumer
I do
piece.
too,
I'll just
but
out myself there.
No, I do too, but I think they fall short in certain aspects,
Yeah,
which is
yeah.
what I personally would like to bring it back into a healthcare setting
Yeah.
and do what they do, only better.
Yeah.
So.
And for me, it's not just a one-time point thing. I think it's important that personalized medicine becomes dynamic. So as we keep treating patients, we actually monitor in oncology what happens to the tumor, and how can we come up with the right combinations, but also with the right dose of the drugs. It's not only what we use, but also how much and how frequent should we give a certain therapy.
So as we start diving down, the complexity just increases, obviously. So the current state is that we don't have a wide variety of individualized treatments yet. Barrett cited for me in our phone call that we had before the session that there's 15, roughly, approved drugs, personalized medicine drugs per se, to date.
In cancer.
In cancer, specifically in cancer. And I guess that leads you to say, well, there are more targets, certainly a lot of targets, but there aren't any drugs. So the field is still tiny as of now. The question is, what are going to be the key drivers of growth? What's going to make this field grow? I mean, in a sense, it's sort of no-brainer. If it works, people will use it, but there's going to be something more complex than that as well. What's going to drive the growth of personalized medicine?
Reimbursement.
Okay.
And I don't mean that in a
No,
cynical way at all.
absolutely.
And even though I cited for you the fact that there are only 15 to 20 targeted therapies for cancer, when you actually do the experiment, I'm going to digress for a second and just tell you that at Dana-Farber and Brigham and Women's and Children's Hospital for the past 3 years we've been doing an experiment to see if we can turn broad-based genomic testing on all patients into something as easy as getting a blood test. And it's a huge experiment. It's required 50 people. It costs us $6 million a year. But we can do it, as it turns out. We see 16,000 new patients a year, and we are offering this test to everybody. We're doing about 5,000 to 6,000. The test is basically like Foundation One. It's a panel of 300 to 340 genomic areas that are examined by next-generation sequencing. So the big question that this project asked is, could you do this? And the answer is yes, you can. But the next big question is, so what if there are only 15 approved drugs? Well, as it turns out, if you do absolutely everybody, if you don't just sort of target a population where you think it's going to be helpful, but you do absolutely everybody, and then you look at the results and you ask yourself, what proportion of these results could lead to a change in the way you manage somebody clinically? Not just is there an FDA-approved drug, but, for example, is there a clinical trial of a drug that's targeted against somebody's abnormality? Does somebody have an abnormality that tells you not to give a certain drug? Is there an abnormality that tells you you should be surveilling somebody in some slightly different way? The term of art we all use is actionable. what proportion of these results are actually actionable? And the shock to me, I thought at best, given the state of the art, we'd be at 15 to 20%. It's 73%. And what that tells me is that when we can get these data in front of insurers, and they can start, they start to agree that this demand that they're getting from their subscribers should be met, then you're going to see this thing explode.
I'll give another example that I think is quite similar, but not necessarily genetic based. If you look at diabetes patients and the number of patients who are managing their glucose levels, their blood pressure, cholesterol at the appropriate targets, only 14% of patients are actually at target across each of those dimensions. And that to me is an instance where you actually have therapies that work, but that the drivers of people not being at goal is actually behavior related or access. So I think there's other ways that you can personalize care beyond just ensuring that you have the right therapeutic match to the right genetic profile. So I think there's a pretty broad space that we can operate in, and that hopefully over time we get to a space where we can line up precisely the right drug with the right disease.
I'm just going to leap onto the reimbursement piece because I think it's awesome to hear from an academic medical center that is doing. So what we're doing is a similar project, but commercially. So for those of you who don't know Foundation Medicine, we do this broad-based genomic profiling, but it's a commercial entity. So we have about 50,000 cases we profiled. The numbers come in around the same. You've got 73, we're doing 85. It's somewhere in between there. But so part of our model is actively taking this to the payer. And I think we're actually working with you now with our local payer.
Sort of.
or in some realm. And this is really the Wild West. I mean, we're taking, so if you think of where the payer sits, they're trying to evaluate drug safety, all kinds of costs of everything they're doing, and we're bringing in something that's super complicated, that has potentially enormous economic returns if we can do the modeling. I don't see that anyone's done the modeling yet, and that's one piece, I think, where there's a huge gap. And explaining the science can tend to become very airy for people, right, rather than, so I think we've had trouble communicating to payers. And the payers, mind you, would really rather go in quite a different direction than any of this.
And what direction is that?
Well, it's interesting. Payers have an anaphylactic reaction to panel testing.
Yes.
The standard of care in lung cancer now is to do 5 or 6 genomic tests. And the payers, after about 10 years of fighting, all agree that they will reimburse for each one of those genomic tests individually. But both Foundation and we, in our panel of 305, say, genes that we test, include those 5.
Right.
So the payers say, I'm not going to pay for your panel because I don't care about those other 300 genes, even though the panel is cheaper than the 5 individual ones. I mean, there's a lot of cultural disconnect that's going on.
Well, and there's the fear of then paying for expensive drugs off-label, I think.
So I want to pretend for a second that reimbursement wasn't an issue. So let's say we're
What color is the sun in your
Can you all hear that here?
But I'm going to try to get to, but there are other factors that will be severe barriers, though. Yeah,
Oh, absolutely.
So let's just assume for now we solved the reimbursement, everybody's happily giving us the money back. What I've been involved in recently increasingly is trying to actually explore whether or not we can roll out preemptive pharmacogenomic testing. It's technically completely feasible, would be an easy panel to do. And what are the barriers there? So and this would be within Partners Healthcare, Mass General Hospital, Brigham, very, very knowledgeable physicians. One of the problems we encountered was there isn't a force from the top that wants it. You know, so there's like people, individual physicians saying, yeah, that might be useful, but there isn't, departmental pressure because there is no department of personalized medicine wanting that. The other thing that will be very, very important, even when that's in place, is that it needs to be in the electronic medical record. So that testing, let's say we do it when the patient walks through the door the first time in the hospital, as we all want it. We have the genetic profile, and we need to put it in the EMR. So the physician has it at his or her fingertips at the time when it's really needed, which is when the patient is in his office or her office and wanting the drug, and then pops up an alert saying like, no, you can't have that drug, you carry this variant. So those are humongous barriers, but they're all being worked on, which is encouraging, but it will take time.
Yes, no, you can pass if you want.
There's two thoughts in my head, and one is, I think they've gotten pretty far in next-gen sequencing on tumor tissue, but now with cell-free DNA, we don't use, like, it's very easy to get the samples. Like, you can get blood draws, you can get them over different time points, but then we need to learn what does it mean if I have a, whatever, 1% frequency of c-Met amplification, or, and people have to be willing to learn. At the moment, we see, well, we don't know what that means, so maybe we should not do it. So there's a lot of cultural issues within companies, even if, like, on the earlier discovery and translational research side, and said, well, it's only costs us additional money, it maybe gets a trial back for enrollment, but we need to commit to learning and figure out what that actually means for our drugs. So that was one aspect. And then I was thinking, so a lot of the markers we are looking at is RNA. And at that, or there it's very difficult yet to do multiplexed testing. So part of the limitation is that you only get a certain amount of tumor tissue, and you're limited to whatever you can do with the limited amount. So new technologies are also needed in the protein or RNA area to actually be able to multiplex and then follow what the path that next-gen sequencing is basically opening. So in some ways, we're only at the beginning of all the data we could be collecting, and then that we need to understand, which is a big challenge.
So that's a slightly different orientation, which is you can see where we're going to be growing. It was interesting because when I said what are going to be our growth drivers, and the very first answer that Barrett gave us, this is what's going to hold us back, because in fact it's antithetical. So, and then when Birgit, you said let's make believe that, okay, so when let's make believe reimbursement isn't an issue, Rachel started to laugh. So, can you explain that laugh a little more?
I mean, I think clearly all entities operate in some way, in some level, with some sort of business outcome in mind. And I think when you don't have a fundamental funding mechanism for a lot of these new technologies or new therapies or new services that will actually be offered, it's really difficult to make it a viable business to run. You know, as I think about many of the startups that we look at, or even the collaboration that we just announced, you know, trying to work out the business model for something that people don't really want to pay. You have to deal with physician behavior change, patient behavior change, payer willingness to kind of do this.
Yeah.
It's a lot of change management that's actually required. So, you know, if you haven't figured out the money portion, it's great that you're leading edge technology, but it'll be a while before
the money follows.
And maybe it has to be baked into the drugs. Right? Maybe it shouldn't be the test that is reimbursed. Maybe it is somehow within the drugs where, because at the end all the targeted therapies benefit from the test. And if I'm the patient, I wouldn't want to get a targeted therapy if I know I don't have the biomarker.
Yeah.
Right. And I think the patients actually should have a strong voice in personalized medicine as well.
Okay, so that leads us to patient empowerment, right? That if they should have a strong voice in it, then we're assuming that they're sufficiently empowered to want to actually have their voices heard. And that's supposed to be one of the key benefits of personalized medicine. So I ran across the KQED Science website with a title on an article that says 23andMe CEO, and then quoted her as saying, "We are now the poster child for patient empowerment." Do you all know what 23andMe is? Most of you, I assume, okay. How do you feel about 23andMe being the poster child? Actually, one of you might want to explain 23andMe
So I-
first, because is there somebody who didn't
I was wondering
know?
if anyone's had 23andMe.
Okay, can somebody
Yeah.
here explain 23andMe?
And we've got someone in the audience who got 23andMe.
No, I asked who didn't know,
Oh.
so, an explanation.
And I could if you
Sure,
want.
briefly, yeah, and then.
23andMe is a direct-to-consumer genetic testing company whose goal it is to, I guess, empower patients and giving healthy individuals largely their genetic profile for all sorts of things, and includes fun facts like, everybody knows the sticky earwax versus the dry earwax stuff, but then they also ventured into the healthcare.
Actually, not everybody knows.
So they test, they genotype, or they determine genotypes across the genome that predispose an individual to certain things, or are responsible for certain things, like, hair color, are you an athlete, likely or not. But then they also decided to venture into the healthcare sector, and they started adding on health risk traits, and actually things that I personally test for in my laboratory. And that's when the FDA woke up and said, oh, no, you can't do that. Now you're crossing the line, and they shut them down for a while. So the company rebounded now, and they actually became CLIA certified, and what that means is that they embraced a regulatory landscape. They opened themselves up to inspections and regulation, as all of us are subject to, and they've submitted a few years back their first just one marker through the FDA, and now they're continuing that path. But I don't know if that makes them the poster child. That's a marketing strategy, right?
Well, it is partially. I mean, she's the wife of, is it Sergey Brin?
Ex-wife.
Ex-wife of Google, right? Ex-wife of Mr. Google, and so she was able to push this forward.
But I will say, sorry to interrupt you, they get a lot of negative press from healthcare folks like me, but I'm actually quite ambivalent, because they have done a really great job in putting it into people's minds and by making the public aware of the power of genetics, which is, and we're operating with a very small slice of individuals, those who are already sick, but genetics is much more powerful if you administer it early in life. So that's what I really commend them for.
Well, I'm going to disagree. I think that they did a great disservice by raising expectations quite unreasonably and implying that consumers, without the benefit of genetic counselors or other professionals, can interpret these minimal risk alleles and can actually on their own modify their behaviors in a way that might be destructive. And I think that there's a lot of originality in the idea, but the mismanagement of the public's expectations could end up hurting the kinds of things that we want to do.
And I actually agree. Sorry, can I respond right away? I agree with that as well, which is why I'm flip-flopping. Remember earlier I said I want to actually bring what they do into healthcare, which is where it belongs. Because of that, and I have an example that really is testament to what you're saying, is a very well-educated, individual that came through our lab and trained, and he was an MD, and he came to me in confidence and said, I did 23andMe and I carried X, Y, and Z, and it was a cardiac risk marker, and what do I do now? I'm freaking out. Can you help me? And he was actually at the Brigham already, So this is, and then I was like, well, how do you actually empower somebody who has no education and is just curious? And then you leave them alone, say, and if you ask 23andMe, they will tell you, oh no, people can read, and we give them websites, and they can go. And I'm very worried about that as well.
The piece I see here, though, is that it may lie somewhere in the middle, because one of the pieces I really like about 23andMe is that the democratization. Right. I mean, we're here in Boston. We're talking about the Brigham. We're talking about the world's finest healthcare systems. And so, if we do internalize it at the Brigham, then what do we see as a model for the patients in Iowa or in rural America who are not going to be able to get this internalized kind of test?
Your company.
Oh, again, but that's for
exactly.
sick people. Right, but I mean, I'm wondering.
So another model, that has a company like yours, in which the physician sends material.
So maybe I think council might be doing this, or maybe other businesses. But I think, I think just as I'm listening to this, I'm thinking, yes, and absolutely, we want this to be democratic, but we do want it to have, I mean, we have staff, I'm on call this week, so I'll have 10 patients call me and 10 doctors and saying, what does this mean and what about that? And we have MDs to talk to them, or genetic counselors. And I think it is scary to think about people. Sometimes on our report, someone will have a terrible tumor, and yet it says on the report, this is a very bad prognostic factor. And you have to talk through with the patient and say, well, we know that this is a bad tumor, right? Because it's metastatic. So I want you to get a marker. I say and cross out that line because don't worry about it. You're already there, right? So I think this piece of leaving patients with scary information is a big and a not good thing, and I think that, and yet how do we democratize it? So
How do we?
I think we do, I think as you say, it's another venture. I think maybe Counsel are doing this. There's a company that's doing this. Is it Counsel Genetics that's doing a consumer-facing genomics? And patients come into us all the time. David, who's in your class here, knows because we bring patients in, and one of the most heartbreaking things they'll say all the time is, it took me forever to find you. And and I think, okay, maybe I'm not a fan of direct-to-consumer, but could we just advertise? Because it shouldn't be so hard for patients to find out how. It should be in the same breath. I have cancer. What are my genomics?
So you
right?
bring
It just,
up you bring up an excellent point. This is physician education. Because as we roll out all this into more general practice, right now it's all in specialty clinics, and that's less of a problem, but eventually it's going to be, we need to educate all physicians, and they don't have genetics training, the older ones.
right.
And, it will require.
I think we have to be a little careful. There are, we did have this distinction at the beginning between population-based studies and the individual precision studies, but, it's population-based studies that tell you what the efficacy of an intervention is. And that still has to be the gold standard, not just from a payer's point of view, but from the profession's point of view. We know that the intervention for, if a patient has non-small cell lung cancer, has an EGFR mutation of a certain class, and they get an EGFR blocker, those patients live longer. What we don't know yet is if a patient with a newly diagnosed cancer, or cancer that's been around for a while, gets a panel test like Foundation 1 or our test, do those patients live longer? We really don't know that yet. So I'd be careful about saying we have to democratize that, because we're going to create a demand for something that we don't really know is efficacious yet.
Yeah, I think one of the biggest concerns that I have is that we have a lot of data. We don't have a lot of knowledge. We don't really know what to do with this data. We have statistics. What do you do with the statistics? At what point do you go from 15% to 30%? And what do I do with my life differently? Right. And that's the problem. So until you do sort of longitudinal studies and see the risk increase and what you did environmentally, behaviorally, therapeutically different to understand those correlations, then I think it's a lot of data. And you have to make your best judgment, hopefully with the guidance of the counselor on what to do.
But also, I think we have to think differently about the data and how the data is being made accessible, because it's impossible to run a study to ask every question, or it's going to get very expensive. So we have to be able to sort of look back and see what happens to these patients that had X and Y. And we still don't quite know what does it mean if I have not only a mutation in one gene, but in 2 or 3, which is driving, or what do I do in these cases? And we need to be able to go back and actually analyze data, which means that the companies need to make the data probably more public than we're doing right now. Also, there's another question of, like, in our trials that are heavily translational, I think we should probably give back the data to the patients or the institutions when we measure those biomarkers, so they can be part of the next intervention or study they go on to. Like, I think there's just something we as a community need to change in how we think about data.
I think Birgit too is right. I described our study, which we call Profile, and I described it in the context of giving information back to providers. But that's not its real reason for existing. That's very, as it turns out, very secondary. The real reason it exists is to take all of the specimen data, put it into a database, which is linked to full clinical annotation of the full clinical history of every single patient. And sitting on top of that is a query tool that allows any faculty member at our institutions to go in and ask a question like, for all women age 45 or older who have stage 2 breast cancer, what's the effect of a PIK3CA mutation on their outcome, on their sensitivity to chemo, on a complication? So that you can actually ask the questions that you're asking. And that's a form of democratization, to take all of this data and make them available. And then there's another order on top of that. The AACR is sponsoring the American Association for Cancer Research is sponsoring a project in which 7 of the cancer centers in the US and Europe and Canada who are doing lots of sequencing are going to combine all of their data and make it available publicly over the next 12 months or so. Again, to allow everybody to get into those data and start to ask these questions.
This is actually beautiful to hear, because I think there's a huge paradigm shift in medicine or research also, and that is democratization of data, as we just heard. And I'm part of one of these initiatives as well, which is called Clinical Genome Resource. This lives more in the Mendelian, so inherited disease space. But the idea is really that you just put all your data into a common database. Is what's happening everywhere, because especially in the rare disease world, which I live in, it is incredibly powerful when you can go into these databases and find another patient, another rare patient that has the same thing, and now all of a sudden you start making sense of it. And before, when we were all very protective of our data, that wouldn't have happened.
And it may bring us more targeted therapies to the market or to approval. Because right now, if you have it, the trial I showed you this morning, without the translational data, it looked like the drug is not doing anything. And if you think of prevalences of 5–10%, it's so varied in the overall population that you'll never see it. And who knows how many molecules never saw the end of the tunnel because we didn't have the tools, or we couldn't really look at the data.
Yeah, I think there's going to be a real shift in terms of research, because we're seeing a lot more industry consortia, academia consortia. One of the interesting studies that people have been talking about is the Google baseline study, which I'm not sure if people are familiar with. But
better explain. If you're not sure, explain.
So it's a study. They're working with Duke and Stanford, and they're studying 10,000 patients. And they're basically taking every data set you can imagine, so the full omics, genomics, proteomics, metabolomics, microbiomics, as well as lab clinical history, and they're biobanking every sort of sample you can imagine, so blood, urine, sweat, tears, stool, exhaled breath. I can't remember what else.
I just heard a sound in there.
Yeah,
I was so admiring that.
What's,
sweat and tears.
What's really interesting, though, is they're taking.
I cut off
to add to that. What's really interesting is that it's called baseline because they're trying to actually enroll healthy patients and then see them progress towards disease, and they're looking at cardiovascular and cancer as 2 cohorts.
Yeah.
And so that's something that, as industry folks, we don't really study people who are healthy. But to have a study like this, where you see patients come in year 1 and maybe year 3, unfortunately, they progress to some sort of disease. And then you have all of the samples, all of the data, clinical and behavioral, EMR, as well as all the omics stuff, to be able to apply big data and machine learning, other types of analytical approaches to that. I think we're going to see much more rapid R&D efforts, because it won't be one-on-one hypothesis testing. It'll be sort of multi-hypothesis testing.
Actually, a question for the panel is, do you think we actually will run into a shortage of people who know how to deal with these big data sets?
Oh,
Right here. Who are MBAs, this is where you should be heading. That's going to be my next question. Is there's this tsunami of data, and the question is, who's going to make sense of it all? Who is going to make sense of this?
I had an idea many years ago when I was on an NCI board and the TCGA was announced with the ERA money. And I said innocently, we should have something like the Peace Corps, and it should be called the Bio Corps. And you could take all these young unemployed youth and start something and teach them how to do bioinformatics, because that's going to be all we need to do for now and forever. And people sort of thought, oh, that's so cute, Deborah. So, you know. And then anytime I could corner someone and say, no, this is for real. As a country, you know, and this is where we're really stalled out. And, you know, but I don't want to lose that track, but you know, when we're talking about the need for this population-based studies, we also have an unintended consequence that, so we're trying to recruit, you know, randomized control, you know, observational trials where patients can either, you know, get the test and either get standard of care or a precision medicine drug. These are nearly impossible to recruit because people are like, no, 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 I want the drug that's going to hit my target. So it's even going to be tricky to get our traditional kinds of data now. You know, that even that is puzzling. So, but that still fits into this whole, you know, crew of, do we have a Peace Corps? Do we have a BioCorps? And it's also something you could really put, you know, people could do it from home, you could do it remotely, you could do it, it could, you know, hire disabled people. I mean, it's got an enormous amount of potential if you want to take it up.
It really has to be a multidisciplinary team that analyzes the data. I mean, you're going to have your computational scientists, but they have to be paired with clinicians, with researchers who can understand it and, you know, make the linkages, because it's not going to just, otherwise it's just sort of correlation analysis. You don't really know what's going on.
Right.
The toughest faculty recruits searches that I've ever been on in the past 5 to 10 years have all been around informatics.
Mm-hmm.
And just everybody needs them. Everybody needs computational biologists, and the pool is really small. And you know, you're right, Deborah, the only way we're going to see this efficacy that I referred to before is going to be with some very clever informatics approach to digging into the data. There was one study that kind of bubbled up to the top, again around a certain type of lung cancer, in which this consortia of all the places that have been doing this genetic testing on lung cancer looked at their populations of close to 1,000 patients, and they couldn't look at who got the test or didn't get the test, because everybody got the test, but not everybody got a drug for various reasons. And then they looked to see what's the survival of people who got a targeted therapy versus those who didn't. It's a really kind of flawed, and you know, the assumptions are kind of iffy, but the people who got the targeted drug lived a little longer. And so what we're going to be, I had a conversation with somebody yesterday about the concept of consilience, right? You're not going to have the definitive trial that shows you the result. You're going to have a lot of these little funky, somewhat flawed trials, but they're all going to point in the same direction. And eventually, when you have enough of these and you have enough consilience going on, we'll realize that there is actually efficacy.
That's going to be my word of the year. Consilience. I'm not sure what it means, but you will be. I am going to be using that word because, yes, it's we have to behave entirely differently than as scientists. And
So the gold standard will not be
no
the
one
gold
will.
standard?
No one
Horses
will
out of
do
the
it.
barn. I don't think we can
People
do it.
will not. You can't recruit these trials. I mean, payers are like, let's see the RCT, and we're saying,
exactly.
sure, we're closing it right next week.
Yes.
You know, we've spent the $500,000, we've tried to do it, and you know, I'm on with these leading investigators in precision medicine, and they're, you know, trying everything they can do, but patients are thinking, I'd rather not do the chemo. I kind of want to go on crizotinib. So, and social media plays in here too, right? I mean, people hear about responses, and then
They go on Patients Like Me. They
Sure.
talk, you all know Patients Like Me, right, where patients, it's a website.
Run by an informatics guy, I'd like to point
Right.
out.
It is, right. Well, it was
Right.
started for the brother, you know, who had ALS. It was the two brothers started the website for their third brother who had ALS, and they wanted to find other ALS patients and find out, you know, what possible treatments there were and what was efficacious and what the side effects were. And over time, they've now added on all sorts of diseases. So whatever disease you have, just about, that's not orphan, you can get on and probably find other people who will share all sorts of information with you. So they get on something like that, and then they say, I'm not going to do a clinical trial because instead I've already seen on patients like me, I should be doing X.
Or they're on the, right, they don't want to do, there's other trials open in that site, they know their genomics, and then they think, sorry, I'd rather go on that NTRK inhibitor than, you know, chemo.
So let me open at this point for at least a few minutes to questions.
I've got a whole bunch. I mean, this conversation has been awesome. I really enjoyed it, so thank you. The first one I had is, we talked a lot about cancer, and I think that's a lot of your guys' specialties, but like personalized drugs for antidepressants and whatnot, which are basically just different areas of medicine. Your thoughts on that? As far as data analytics goes, do any of you work with Flatiron Health down in New York?
Probably we all do.
Yeah.
We've all heard it.
We work closely with them, and it's tricky to get. We're still early enough. I'm sorry.
Explain what Flatiron is.
Yeah, go on.
Okay, I'm not good at explaining what Flatiron is, but Flatiron have a way. They're a company. And jump in if I'm wrong, but they have a model where they can suck data out of EMRs and do it neatly. So we work with Flatiron and Foundation Medicine to say how many of our patients are also in Flatiron, because our goal is to get to what you have, which is where we can see the genomics and the phenotype and the other clinical data of a patient, because genomics alone is just numbers, it's just genes, right? I mean, we have the genomic database, but without the clinical information, it's kind of nothing. It's only for research base, really, or to tell you prevalence per disease. Flatiron purports to be able to help combine some of that data. There's other companies navigating cancer that do something like that may have more space, more in the cancer space. The problem with any of these, as my friend who runs Navigating Cancer, full disclosure, is that the way our data sits now in these different electronic health records, it's like the early days of the railroad. They all laid down different tracks. So if you're on Epic, you've got one track. If you're on another one, all different tracks. So the idea of these all eventually coming together is like the pretend world where there is no need for reimbursement.
Yeah,
It's a huge problem.
Yeah, but this points out an interesting thing that is a little bit off track from precision medicine, but not too far, which is that the electronic medical record, and this is a huge issue, we're approaching the situation where over 50% of every individual in America is currently on an Epic system. Epic is one of these enterprise electronic health records. But I'm a capitalist. I live in America, but it seems to me the electronic health record ought to be a utility and not. We should not be leaving this to private companies.
No.
It's just way, way too important.
Yeah. Well, this is what Gina at Navigating Cancer wants to start a patient movement to say, really, this should be like the railroads. Amtrak could take it over. We need to mandate it.
Maybe a better.
Yeah, maybe better than Amtrak could stay on the rails. But there is apparently some guy in town, because I mentioned this the other day, in one of the Harvard hospitals that's working on doing this from a venture point of view, not from I was talking to Payer, actually, at Payer at Horizon. So I'll try to find out who that is. But this is another whole piece where you're suddenly looking at a bunch of puzzle pieces thrown on the ground and thinking, oh, those are going to come together somehow.
Yeah, there's certain basic enablers of big data that just aren't quite there, and we're just sort of like hodgepodge picking different
Multiple
point
platforms
solutions.
that don't talk to each other.
I did want to address your first question in terms of are there other diseases beyond cancer. I think cancer is probably the most documented, but there are certainly many other diseases that are starting down this path of personalized health, certainly the rare diseases. But I think every disease is now trying to take on that view. Even the chronic diseases like diabetes and cardiovascular are also heading on the path.
Do you have a third one? You said you had multiple.
Yeah.
I'll give you a chance while you're on here.
Sorry, guys. So, Birgit, you mentioned like preventative, and I'm just wondering if you think that 23andMe has like a place in that, like slight lifestyle alterations to help prevent as opposed to treat like a medicine.
I mean, that's what they want, but I really do think it ought to be brought back into a healthcare setting. But we need to find a way to open this like that up to healthy individuals, because that's not completely easy to do today. If I were to go to my physician and say I would like that panel that, let's say, my laboratory offers, because I hear that 1 in 200 people have hypertrophic cardiomyopathy and it's not overt, so I might get it when I'm 50. They would say I'll come back when you have symptoms, or,
Right.
and it might be too late because the first presenting symptom can be sudden death, unfortunately. So I mean, this is a bit of an extreme example, of course, but that's, I guess, the point here to polarize.
Well, not seeing that.
Picking up on what Barrett said earlier, I think there's a more fundamental question: is how much should be done by private companies versus maybe more government. Like, I'm not sure if the idea of having all the data, like patients like me or 23, like in companies' hands, and who whatever learns from the data and makes money from the data at the end, which may or may not be in the interest of the patient or the person initially. And I think that's a big difference sort of in the public opinion in Europe versus here. People here are a lot more open to just donate the data to whoever. But I think it's a big ethical question.
So in my business, we are now obligated to return the data to the patient. So that wasn't the case until maybe a year ago. But there's a law now that says if the patient wants the data back, you have to give it to them. And we're actually dealing with it. And how do you give it back to them? What is it? You know, because this is massive amount of data, and we're afraid that the patient then turns around and goes to somebody else who doesn't really know what they're doing, and you know, but we have to do it. So I don't know if that's the same in your research.
Well, in the trial, we do want, we haven't done it yet, but we want in our future trials actually give the data back to the patients.
Are you allowed to?
I think so.
From a compliance perspective.
Only if they consent.
Yeah.
That's right.
Yeah.
And our patients are unconsented, so.
You had a question.
So I think the idea of getting all the data together from all the different places is great, because the more data you have, the more likely you are to, even for rare clinical situations, to find something to help each and every patient. But it's also a really competitive environment, especially in the environment of reimbursement challenges. So how do you encourage companies and various players to work together or work with some third party in a way to actually get everything together and get it in the same format?
It's an interesting question. I think this is why I actually referenced the Google baseline study, because that's one where they are trying to pull all the data, and they're talking to probably every pharma here to try and participate, because to do some of these things and to deal with the EHR lack of integration or ability to kind of cross-communicate will require, you know, industry coordination and cooperation to do that. So, you know,
And in terms of the competitiveness piece, commercial competitiveness, I think there's a real change happening in most sectors, and that is that we're all realizing that yes, you might lose some, but you will win more by pooling, you know. And I mean, at least the slice that I oversee, that's very true, because maybe 5 years ago, we actually actively said in our management meetings, and it was discussed, should we not open our database, our internal database up? Oh no, this is our IP, this is sort of our business, and it's gone. It's gone. We actually, you know.
I wonder if it's, so I'm thinking about two things that happen in my real life day to day. And both of them involve academic medical centers, not particularly identifiable ones. And one is where we're considering doing a data share in a rare disease. And we want to say, put this in through a gateway and say, have at it. Rare disease, here's 2,000 cases clinically gathered, here's all the genomics. And the person, and in one of these, there's an academic center where they've contributed a large proportion of these patients. And where they were initially quite excited and they wanted to do this morning there was well, we're publishing our big paper in January, can't you wait? And so you're put with this, it's kind of a flip, whereas industry is saying, have at it. This individual's thinking, well, I want you to do this, but can't you wait until I'm putting this paper out? Because for his survival, he's got different metrics, right? And then we sort of process that and think, well, the raw genomics shouldn't really affect your paper. Okay, so that's one scenario where you suddenly think, wait, now it's industry saying, here, just take this. Another was that, this one is a little more tricky. So I did something, I did an abstract, and I'll be presenting the data, and I am outcome poor. So if I had some of your patients, I would be calling them up and saying, hey, remember that? Do you think could you remember this? So I have to call up doctors and beg for, do you have some time? Can you tell me this about your patient? I'll put you on the poster, I'll put you on the paper, this kind of thing. And so this is what we do as a company. You have all this, we can do all the analytics and bring the person along, but we don't have any of the outcomes. So in this one instance, I'm presenting, I've got a form, I've got 45 minutes, and another major center said, no, we're publishing this data. We don't want to give you any of those outcomes for that, so please don't even mention our name in the presentation. And I don't, and I thought that fair enough, but this is really academic sparring that's of a different, and I don't put any blame there, it's a different environment, and yet, we all have what the other person needs on one end, right? So it's navigating it.
Yeah, I think this can be handled. When you think about just what's happening in academic centers, so for the consortia of 7 institutions that have agreed to put all their data together, there has to be some consideration for a couple of things. One is that the ability for an academic to work on a data set and publish in that data set is not a minor issue, it's an existential issue. And no, I'm absolutely serious about this. This is this person's livelihood of life.
Yeah.
But, as Birgit once said,
Which one is one?
the first I'm sorry, Birgit Eins. There is ultimately more benefit in being able to look at that larger data set, as you implied. And so what we created were safeguards with incentives. And the safeguard is that when an institution puts all of its data into the central database, it will not be available for public analysis for 6 months. Mm-hmm. And for 6 months, we figured that's a sufficient window for the home institution to get their act together. Right. And if they can't get their act together in 6 months, then I think the technical response is screw you. We're going to make it open because that's and we go back to I have to go back to my faculty, for whom again this is an existential threat, and say, look, you can do this in 6 months, and if you don't, we're going to do this anyway because you will get an even better paper. You will get an even higher profile, higher impact result if you can use the data from all these places. Right. So you can ultimately kind of figure out a way to navigate.
Yeah, and I think, and that's super helpful for me to hear because this is just in my little world kind of saying, oh, I was asked to present that data, and really being pretty oblivious myself to the fact that this was mostly from another center. I'm just thinking of it as our data because we own that data. Yours. But we actually own the data, right? So
you only own the genomic data.
Exactly.
You don't own any of the clinical
exactly.
data. And not only do you not own the clinical data, the person who has the clinical data may not be authorized to give it to you. Yeah. There are HIPAA requirements that keep them from giving it. Well, and that's not necessarily a bad thing.
No. And
somebody has to agree. In our protocols, we try to get every patient at our institution to agree that we can send their clinical data to a third party.
Right.
And 70% of our patients will agree to that. 30% won't. And there's just nothing you can do about that 30%.
Right.
They're entitled to the privacy.
Yeah, I tell that to expose my own naivete here and to just say, as one is trying to do the right thing, bring data out, say, in sarcomas XYZ, there's the daily pitfalls of like, oops, I've just stepped on the toes of, an entire now angry kind of group. And
but yeah, I think a lot of the consortiums will have these time sort of exclusivity periods during which they'll do their research, and then you bring, it's BYOT, bring your own tools, right, to the data set, and whoever brings develops the insights from it will be able to patent off of it, but you can't do the insights without the rest of the data. So I think the incentives to pull it, you're going to be able to structure those in a way. But I think to respond to Birgit, too, sorry, on the government versus private, I guess I'm a capitalist at heart, and I feel like enabling these small startups to push the envelope will give us faster ways to think differently or to get at the information, and eventually the government needs to step in and put in the right ethical framework, and ideally you have that first, but I think to really get the innovation faster, keeping it.
I agree. I think what triggered it for me was we've been working with PanCan as a patient advocacy group, the Know My Tumor initiative, and then patients like me, and then it's like, well, in some ways we almost trust the advocacy group more to be really open with the data and serve everybody, where it's not quite sure what is the business model on the patients like me side. So it's just, it's sort of, I agree with you, we need groups or startups to push the envelope, but at the end, you want to make sure the data is accessible to everybody. And I don't know, I think it's just a very interesting ethical question. You can also argue that maybe if it's owned by the government, maybe that's not good either. So it's, I don't know, but it's certainly not that easy.
Yeah. Actually, speaking to another ethical question that I had, back to like making medicine more proactive versus reactive. The thing that I always go back to is this movie I saw a long time ago that really freaked me out, Gattaca. And it just, you know, is that a possibility, and how do you control for that? You know, when we want everything to be open and we want to know as much as possible and make it preventive and proactive, but when is it that maybe it's to the point where you can, you know, maybe harm society or harm people?
I mean, that's a really, really good question, because with everything good comes a potential of bad. And I mean, I think you need the lawmakers to come in, and to some extent it's happening. You know, like Gina is there, although Gina doesn't apply to life insurance, so there still is the risk that you're discriminating. So I was actually just thinking about that as we're talking about making data sets available. So in my world, that means a genome, because we're sequencing genomes clinically now, diagnostically. And a genome is makes you identifiable.
Right, yeah.
You know, so anyone can go in, and if it's sitting, they're going, you know, so and so has this disease or will have that disease, and you know what? And then you're screwed if there's no, pardon my French, but no better legislature out there. So, but I still think, I fundamentally think one should always push for improvement and not get too scared, and not to the point that you don't take that step. And that would be sad. But I didn't really answer your question. I'm sorry.
Just a quick question. I was wondering about the difference in the terms where you hear personalized medicine, and then I was reading in the New England Journal of Medicine, and they refer to precision medicine. Are these terms interchangeable, or do they mean something different?
I think one is now more the fancy term, precision medicine. I think that's what would be my.
I think they mean different things.
I think they mean different things. Yeah.
Really? I don't think they do.
I think they do.
I think
Let's hear what you think it is and what you think it is, because.
No, I mean, I think precision medicine for me tends to have the direct match of sort of genetic testing and the therapy, and it's like very, you know, there's personalized. I think it's just customized, you know, care and therapeutic protocol.
And any good doctor
is going
to be engaging in personalized medical care.
Yeah.
But even the best doctor may not have access to the data to be precise in his or her care.
So maybe the precision medicine is now the fancier way in genomics of implying it. We used to say in genomics personalized medicine, and then we kind of went into precision medicine, at least from the companies.
I mean, I think the term personalized medicine was the first.
Yes.
And it got sort of attached to largely pharmacogenetic, you know, things like, can you take that drug when you have that genotype? And then that discussion started happening, well, anything is personalized really when you're a physician, and that's when people started looking for another term. And I remember seeing a paper actually polling people, like, what is the better term? Is it personalized or precision? I think for the reasons you stated, precision medicine is what we mean, actually. But personalized is sort of what started it, and that's why they both exist.
Okay, so.
There was another question.
Oh, was there? I missed you. I'm sorry.
Is that okay?
Yeah, sure.
Just a quick question on, I would agree that I think this is where healthcare is going. If that starts to be somewhat the standard or the norm, do you think there'll be pressure on having everyone do this when some people may be averse to knowing in advance what may happen, even though that may mean they could potentially get better care or prevent things that they would know? Like, how do you think that will play out in the future?
I think it's a spectrum, because I think for diseases, well, for ACOs who are going to reimburse this, they'll only do it for things where it's actionable in 2 or 3 years and affects their plan in 2 or 3 years. For things that you're preventing 10 years out, I don't think we really have a funding mechanism to pay for those kind of tests. So I think it'll be a spectrum in terms of where they will encourage testing and preventative measures, and others that you're just not in the profile. It doesn't make sense to test you so early. I don't know.
I mean, in the non-traditional precision medicine sector, just to have an example, which I think is actually illustrating what the theory that you're describing, which is non-invasive prenatal testing for aneuploidies, and it is actually very easy now to do, and it detects them very early. As names as non-invasive, so easy to do. And there's a huge discussion in the community on whether that will actually make people who don't want it, be labeled as, whether there should be pressure to actually do it that early, because you can. And so I think it's a real possibility.
But some 1984 or some other sort of, you must have this done so you know what's going to happen to you, so you take the right steps to protect yourself with no choice.
Yeah, because the people have all sorts of reasons for not wanting, even if it's beneficial, right? I mean, they could be a religious reason, and who are we to say you have to have that done? I mean,
So we talked about reimbursement, because I asked about growth and immediately I hit the barrier, which I understand fully. But there's also cost, which is sometimes not exactly clearly related to reimbursement, certainly, but what about the cost of this? Where are the costs going to come from? Where are the costs going to drop dramatically? And where are the costs going to stay really high?
Maybe I can start. Like from our perspective as a pharmaceutical company, we want to develop with each of our therapies a companion diagnostic.
Yeah.
And so it is, we really believe that it's important to spend a lot of money in our clinical trials to learn as much as possible in the early stages to see whether our drugs work in the patient population that we thought it should work, and to prospectively select the patients also already as early as we can. We believe that it's important as our business model that the drugs basically pay for the diagnostic, because it will be very difficult to make money on the diagnostic.
Okay, so we're assuming that reimbursement will not be there for the diagnostics.
That's our assumption.
Reasonable assumption?
Well, that's our business model, right? So
I'm asking, I'm not telling you.
I mean, I think it's a really good question. So, we had Roche Pharma, not Roche Diagnostics, take purchase of 56% ownership of our company. And I think in the first week of that happening, many of us thought, well, finally, can they just absorb this cost? And, they're a big pharma. Why, this compared to the cost of care, the cost of the therapy, the cost of the R&D, et cetera, this is it's our tests retail is about $5,800. This should just be absorbed, right? I mean, is there a way to absorb this into the cost? There's nothing that may happen over time, but I think it would be amazing, right? Because this should not be where we get stuck, where people are afraid to order this, and we offer all kinds of financial assistance. I think most everyone in town, we're just eating the cost of the test. Everyone is, we're getting paid a certain amount for our test, but it's not covering our test. The patients are not, it's also not our business model per se. We're more of a pharma business model, but again, for to maintain a healthy stock price, et cetera, you want to be getting paid for what you're doing, and based on that model. And it's proven to be incredibly difficult. And again, I think for to keep going with if the Farber are going to continue to do something like that, you're just, this is not a cheap thing to do, right? We were funded to the tune of $200 million to do this, and you guys are doing it at a much more affordable rate, but it's a lot of people, it's a lot of analysis,
And
and
not every hospital will be able to do it.
exactly, right, so it's a tricky,
I think there has to be a reimbursement.
yeah.
You know, with respect, Birgit, I don't know what the public's appetite is going to be for tacking on an additional cost or additional price for already very expensive anti-cancer agents. You know, already, you know, there's tremendous resistance.
No.
So I think the more hopeful path would be to convince payers of the benefit of reimbursing for what's essentially a cheap test.
Yeah, but it might depend on what test it is, right?
Well,
Like,
I think
if it is, like in your case, a large panel, if, like in our case, one of the markers may not necessarily be on the panel, and it's maybe a separate test, then it might look different.
Yeah, but let's say it is on the test.
Yeah.
It is on the panel. I think what the payers want to see is what Deborah was referring to. You know, our approach has been to test everybody because it's an experiment. But what the payers want to see is what's your algorithm for deciding who gets tested and who doesn't, so that we're not stuck paying for a very expensive drug which may not have any efficacy. If you have some kind of decision analytic tool that tells you that the only patients you're going to test are those likely to be cost effective in their therapies, then we'll think about reimbursing.
So that brings up preemptive testing, which I think you had mentioned before. Are we going to end up going that route, do you think? Preemptive testing?
Preemptive approvals?
Well,
Or-
you know.
Preventative.
Preventative,
Oh,
essentially.
But maybe before we go there.
Yeah.
I wonder, like the panel, I think has a lot of benefits because you could, at the moment we only have 15 drugs that the patient might be assigned to. Hopefully soon we have more and more options, and hopefully we've sequenced not only once but also whatever 3 years or sometime down the road in the treatment to figure out what's the next line of therapy. So ideally, you get an answer for a targeted therapy from the panel, and then it's just something we do. It's not that we choose a certain patient population.
Well, that's certainly our argument. You know, again, as I said at the beginning,
So-
turning this into getting a CPC, but the payers aren't there yet.
Yeah.
And the payers are really moving in quite the opposite direction. We do a lot of work with the Patient Advocate Foundation and the National Patient Advocate Foundation around trying to understand this policy stuff. And really where the payer world is going is towards things like clinical pathways. And this is kind of an eye-opener that, you know, for in these clinical pathways, so you may be insured by one of these companies, right? And you wouldn't know that your doctor was actually getting paid money to follow a certain algorithm for your care. And if he or she veered from that algorithm, he or she would not get that money. So, so you're coming in, you've paid your insurance out of your paycheck, and your doctor may be thinking, okay, I can do this thing because then I'm going to get $250 if I give you this, if I go this way.
I think, you know,
That's well point.
That's still in the
I mean, that's what's
fee-for-service kind of landscape, and hopefully, you know, with the shift towards taking at-risk, you know, organizations, accountable care organizations, some of those funding mechanisms are different. It's no longer fee-for-service, but rather for a patient for a certain, you know, disease, you're paid capitated amounts, and then everything that you do is covered under that amount. So hopefully things like testing or whatever will get wrapped into that.
These are very restrictive, though. I mean, if you look at the clinical pathways and how they're going to, you know, and even the blues are all going towards below, you know, care that is below the, you know, clinical evidence guidelines, right, in cancer. You know,
I disagree
well,
with that.
Michigan.
The pathways that I've seen are very much evidence-based. I don't have sort of the same allergic reaction to pathways. I think there's a lot to be said for standardization of care in this country. There's a lot of waste.
I think if we had transparency and doctors were not getting kickbacks without the patients knowing, I think that
I don't think that's a kickback. They're getting paid for taking care of the patients.
I would rather know if I were on WellPoint that my doctor was getting paid to do to follow an algorithm. I just think that level of transparency would be, because I would rather not go to that person, right? So, and that would just be my personal choice. You know, so I think it's, I think there's things that the population doesn't know and would be, it's the least someone should know, right? If we're paying for this insurance ourselves, so.
So, since I don't see hands, I have a couple more questions that at least I personally found interesting. One is I'm familiar with incidental lomas, meaning you discover something in the body you weren't looking for. What happens when you discover something in the human genome you weren't looking for, and do you tell the patient?
Okay.
And do they want to know?
Yeah,
And what will they then? How do you handle it? Who's paying for it?
Well, we tell them everything, so we find lots of novel genomic alterations, and they all go back.
So it's all about, this is talked a lot about in the context of exome and genome sequencing, where you have the power to stumble across those things if you choose to look. And that's exactly what the critical point is, if you choose to look, and that's in the hands of the patient. So they're consented by the physician before sending the testing, and the question is, do you want this additional knowledge? So you have cardiomyopathy, we're going to send for an exome for that, but you might find out you also carry breast cancer. Do you want it? Yes, no. Some go further and say, do you want certain types of disorders to be, returned to you when they're found incidentally? Right now the Mendelian, the inherited disease community is focusing on a small set of genes which the community has sort of had panels decide on are most actionable, of high interest, and you have an ethical obligation almost to return this. And but the patient still has to opt out when they don't have to, they don't want this. So is it reimbursed? If the insurance company pays for the exome, they pay off for that as well, yes. But the question is, do they pay for the test?
So first of all, do they pay for the test? But on the other end of that, so you found something, and there's no treatment for it. Do you tell me? Do I want to know? And how do you know if I want to know? You can't find out without asking me. Which then I say, well.
This goes into like what is defined, what is returnable, and right now we're all encouraged to stick to a certain list of genes which have been vetted with that in mind. But this is not. Yeah, people always think people wouldn't want to know if they can't do about anything about that particular finding. So Alzheimer's is the best example, maybe. You find out your risk for Alzheimer's, you cannot change that outcome. And actually, a colleague of mine, Robert Green, he actually ran a lot of trials on that, and found out, much to my surprise, also that people actually, the majority of people wanted to know, and they actually used that information for other good things. Even they changed their life in other ways, making the best of it. So it's a complex question.
Yeah.
But if societies come in, professional societies, and inform on what genes are, actionable, what's I mean, if it's well titrated, I think it can be used really, really well.
So from what I've heard from the panel so far, personalized medicine is a very interactive mechanism. So that brought me to the question of patient education. So I just think there's a huge gap between the information that can be made available to the degree of knowledge an average patient has from a payer's perspective, from a provider's perspective. So when I think about, from a payer perspective, the complaint that everybody has been having is healthcare insurance is very opaque. Like, people don't understand it, and that, led me to think like a company like Oscar, the startup in New York that has the mission of like making healthcare insurance transparent, and has been failing for the most part. And from a provider's perspective, going back to your earlier point of providing, like 23andMe, providing information in terms of like genetic disposition to diseases to patients, and that brought the question of like, would patients get information and understand how to appropriately react to that information? So I guess my question would be, what would be your thoughts in bridging the gap in all aspects in terms of patient education?
Well, I think you started that off with, not to accuse easy, but having sort of counseling or clinical guidance, I mean, I think it's actually really hard to do direct-to-patient education, just sort of into the mass without knowing sort of what did you test for. Everything's in a context. So, these days everybody Googles the information, but that's sort of just the superficial information you can have. And it's not nuanced with you. We want personalized. We don't want Google answers. So.
Those are the most sought after professionals right now as counselors for that reason,
Yeah.
because there's such a gap between the physician layer and then the patient. And
So we as a company tried with our kind of the low-hanging fruit, which is lung cancer, because that is a disease where there's a lot of personalized therapy and where genomic testing has high yield. And so one area we've taken on as kind of a pilot is working with patient advocacy groups, and I have a background in patient advocacy myself, so working with them to see how do we educate, getting groups together, leaders in patient advocacy, specifically in lung cancer, around if they will, how would they like to have this information disseminated to their groups. And we worked with them for about a year and helped, fund some of this, and they came up with a slogan, "Don't Guess, Test." And we did a series of seminars and webinars and so forth. So I think it's a way of at least trying to bring awareness there. Now again, this is company driven, so that's really happening. And yet we're supporting these groups. So I think those are some of the ways we're trying to do this. Also now we're expanding slightly into rare tumors. I had a call from a group, cholangio group today. Cholangiocarcinoma is another rare tumor, a deadly tumor. And they are asking for that, right? So they're saying, we want to help our, this woman here gets 5,000 hits on our website a week. How do we help them get access to genomic testing? How do we help them do this? So we get requests from patients and patient groups, and yet you don't want that to be delivered in an overly commercial way. You want to, do it in a balanced way. So we do our best to do that.
I realize that it's a little bit past when we're supposed to end, so and if you don't mind, this was wonderful. I think we all learned a lot, goodness I did. And I thank you all very, very much. This was extremely educational, so thank you.